Dr. Garima Sharma is the Director of Cardio-Obstetrics and the Director of the Cardiovascular Women's Health at Inova Health System, a collaborative effort of Inova Shar Heart and Vascular and Inova Women's Services. She is a national leader in women's health and preventive cardiology. She's board certified in cardiovascular disease and sees women with cardiac disease during pregnancy. She treats hypertension, spontaneous coronary artery dissection, and lipid abnormalities, and she will explain to you what that is because that's a mouthful, and works with patients with risk factors for severe cardiovascular disease who are in menopausal transition. Her clinical and research areas of interest include pregnancy, preeclampsia, maternal obesity, health disparities, postpartum prevention of complications from hypertensive disorders of pregnancy, spontaneous coronary artery dissection, cardiovascular health in women, and gender inequities in science and medicine. Dr. Sharma completed her cardiovascular training at Temple University in Philadelphia and subsequently was on faculty at Johns Hopkins University School of Medicine here in Baltimore. She was the founder of the Cardio-Obstetrics program at Johns Hopkins. She joined Inova with a wealth of knowledge and experience in the management of cardiovascular disease in women across their lifespan. She has published more than 100 peer-reviewed articles in the top-tier academic journals and has led several national and international educational conferences in women's cardiovascular health. Just in the last week or two, she co-authored a landmark guideline in the American Heart Association publication. Dr. Sharma's research has been awarded funding from the National Institute of Health and the American Heart Association, and she's published extensively in the Journal of the American College of Cardiology Circulation and the Journal of the American Medical Association on Women's Health. So, Garima, if I haven't embarrassed you enough at this point with this introduction, we are really lucky to have Dr. Sharma here at Inova with us. It's just fantastic to have her, and I look forward to her talk. And I'll be back with questions. Dr. Sharma, please take it over.
Thank you so much, Dr. Levy, for such a warm welcome, and thank you to Rana for putting this up during Heart Month. And thank you all to all the participants who've taken time from their personal day to come and learn about women's cardiovascular health. And Dr. Levy, it's my honor and pleasure to work with you. And you know, it's such a wonderful environment to work with. So it's just definitely a great plus to my own career. And thank you for having me. I'm going to try to share my slides, and hopefully they are from the beginning, and you can see them the way they are. Let me see.
I think you're a couple of slides down, so you want to get back to the top there.
Okay. Can you see it now?
There you go.
Okay.
Leading causes.
Is that good? And I wanted to make sure you are seeing the presenter view too.
You're good. Yep.
Good. Okay, perfect. So this is going to be about a 20-25-minute talk because we wanted to leave plenty of time for interaction and questions. And as Dr. Levy mentioned, please put in your questions in the Q&A box and think about questions that are general. I wanted to take this opportunity to talk about why we need to know about women's cardiovascular health and what is different in cardiac disease and cardiac disease processes in women across their life course. And as I go into this presentation, I want the audience to really think about health and heart health across the woman's life course. What are some of the risk factors that are different in women? What can we do to identify those risk factors? How do you engage your physicians, your clinicians, your nurse practitioners, your basically your providers to provide high quality, sex specific or gender specific care? And how do we identify ways of identifying heart disease earlier in women across their life course so that some of these risk factors can be mitigated in time? I put this slide in my talk because I wanted to help the audience understand that it is heart disease or cardiovascular disease is the leading cause of death in women. It kills more women than breast cancer. In fact, it kills one woman every 34 seconds. And heart disease can be of different types. It can be heart failure, it can be a heart attack, and complications of a heart attack. It can be valvular heart disease, and it can be other risk factors that are strongly associated with heart disease. And while we hear a lot about breast cancer, and we really focused a lot about early identification of breast cancer, somehow our efforts in identifying heart disease in women have lagged behind. And since 2014, heart disease both in men and women has increased. And during COVID and post-COVID, we are seeing an exponential increase in heart disease-related deaths. The American Heart Association publishes a yearly update of heart disease statistics. And somehow that is also related to the general public audience. And I encourage people to look up those heart disease statistics, because the point of these webinars is that we do not become a statistic. We recognize our risks earlier, and we mitigate and identify those risks and do something that we can work with our doctors and our clinicians to reduce those risks. I put this in here because it is cardiovascular disease is not a man's disease. Gender does play a significant risk factor. 64% of the women who die suddenly from heart disease or heart artery blockages have never had a previous symptom. So the first time they may have a symptom is in the onset or in the setting of a heart attack. 80% of heart disease and stroke events may be prevented by lifestyle and lifestyle changes. And so even though many women may die for the first time they present with heart disease, it is still a largely preventable problem. And I put this in here because there are certain risk factors that are associated with women that women may not know. I put this slide up here so that we can take a look at what are some of the traditional risk factors associated with heart disease, and what are some of the sex-specific risk factors that are associated with heart disease. So while we know that obesity, diabetes, hypertension generally are both in men and women, we need to recognize the differential risk, which means the increased risk to women as compared to men. So there is an increase in the prevalence of obesity in women, and it has a stronger association and a stronger pattern of central adiposity as it affects women's cardiovascular health. Diabetes has a stronger association, a 5 times higher risk, and faster modeling and change in the heart structure and function and stiffness, and increases exponentially the risk of developing arrhythmias in women more than men. Hypertension, the prevalence of hypertension increases in women, and increases in women fast and very quickly after menopause. The impact of hypertension, such as the hypertrophy of the heart, which is the thickness of the heart, and the dysfunction or the heart failure that associated with the heart, is higher, and is strongly associated about 2 to 3 times more in women than in men. Women also have a type of heart disease called a non-obstructive heart disease, where you don't have the typical blockages in your heart as compared to men, but you are just as likely to have heart disease and heart disease symptoms and chest pain as compared to men. So recognizing those differences in traditional risk factors is really important. If you have any of these traditional risk factors, talk to your physician and your clinician about how it impacts your health. On the right side is the sex-specific risk factors. What do we mean by these? These are certain risk factors that are predominant in women, and they have a very high predilection of being associated with heart disease. Sex hormones and menopause. We know that after menopause, estrogen, estradiol, testosterone, all the types of sex hormones decrease, and it is associated with changes in fat, changes in the central fat layering in the body, in your blood pressure and your cholesterol. And I will be talking a little bit more about that in detail. There are certain pregnancy-related risk factors, such as preeclampsia, which is high blood pressure that happens in pregnancy after 20 weeks. It doesn't really impact just the baby, but also the heart health of the mother several years after it has occurred. Gestational diabetes, preterm labor or preterm birth, small for gestational age infant, which is smaller babies, and recurrent miscarriages. These are very specific adverse pregnancy outcomes. If you have had these outcomes, talk to your clinician about your own specific risks to heart disease. Also recognize that there are other outlying, as we call as risk factors that may not necessarily jump out. But taking a proper pregnancy history and asking our patients about their pregnancy is important. And one other thing that we have recognized in recent years, and we are seeing a lot of women who have these problems, is infertility. Patients who are undergoing infertility treatments, especially IVF, are at an increased risk of developing preeclampsia, not specifically because of the procedure itself, but women are entering pregnancy at a later age and maybe have underlying risk factors that cause infertility to begin with, that have an additional impact on these cardiovascular risk factors. We talk about cardiac disease in pregnancy, and I put this slide in here because at Inova and at Virginia Heart, we manage a variety of patients that have heart disease, not the ones that just have traditional established heart disease, but also patients with adverse pregnancy outcomes that I just talked about. If you've had these adverse pregnancy outcomes, you have to be seen in the postpartum timeframe. We now call postpartum timeframe as the fourth trimester. These are from birth to at least about 12 weeks postpartum, where your health is actually critically important. So if you've had any of these adverse pregnancy outcomes, the panel on the right, you have to be seen and be plugged in with your clinician to talk about your cardiac risks. I talked a little bit about it, but I want to sort of hone into these. There has been actually a recent significant increase in adverse outcomes, such as preeclampsia. The rates of preeclampsia have actually doubled, and doubled in specific populations. Black women are at an increased risk of dying from preeclampsia or having preeclampsia, about 3 times more likely. We've also known that patients who are entering pregnancy are also at a higher risk of already having hypertension. So if you already have hypertension, your risk of preeclampsia increases. And pre-pregnancy hypertension, hypertension before pregnancy, has increased as well. And it has increased exponentially in our rural populations, as well as in populations that are already underserved. So this is a really important risk factor. Preeclampsia is about 4 times more likely to be associated with heart failure, 3 times more likely to be associated with heart artery blockages, and 2.5 times more likely to be associated with stroke. About 10% of patients with preeclampsia will be hypertensive at 12 months. This is a very, very large number and large percentage. And so these are patients in their 20s and 30s that have developed a risk factor that will be staying with them as a chronic problem for the rest of their lives. So how do you prevent preeclampsia? How do you be seen for preeclampsia? And how can you reverse that trend is exceptionally important. Pregnancy and heart disease is important because it ties in with your future heart health. And I do want to talk about the 5 steps of heart health in pregnancy. Recognize your own risks. Talk to your doctor. If you're at an elevated risk, talk to your maternal fetal medicine doctor or your OB and be referred to a cardiologist. Exercise regularly. Keep your weight gain under control. Track your weight. Track your nutrition. Do not smoke. Do not drink during pregnancy. Eat a regular healthy diet. Mediterranean type of diet is associated with less risk of preeclampsia. Lots of green leafy vegetables, legumes, fruits, grains, and nuts and lean meat. and limit your salt, limit your caffeine intake, and just be very, very mindful about these 5 tips. I talked a little bit about postpartum health, but I do want to bring this up, especially in our patients desiring pregnancy, as well as patients who are currently pregnant or in the postpartum timeframe. Hypertension can also occur for the first time when you're postpartum. So while preeclampsia occurs during pregnancy, it can also occur postpartum. And usually the risk of postpartum hypertension is about a week after you've delivered. And so these patients are not necessarily in the hospital when this is happening. So what are some of the risk signs? Headaches, vision changes, chest pain, heart palpitations, a high blood pressure. If you're tracking your blood pressure at home or you're monitoring your blood pressure at home, a reading of 140 over 90 is concerning. Talk to your doctors about it. If you have difficulty in breathing, leg swelling, shortness of breath, any of these symptoms, they have to be addressed right away. There's an increased risk of heart failure if you don't. So talking to your doctor and calling 911 as an emergency if you're having very, very significant problems such as vision changes or breathing changes. I'm going to now talk a little bit about the differences in presentations of traditional heart disease and traditional heart-related issues in men versus women. And I talked a significant amount on pregnancy. We're going to try to move away from that and focus now on just the traditional presentation of heart disease in women. What are some of the signs and why are they different? So while a significant portion of men will present with the very classic pain in the chest, arms, neck, jaw, shortness of breath, indigestion, feeling, or sweating, women may also present with those symptoms. We tend to call these symptoms atypical, but we're moving away from that terminology because it's not really atypical if 50% of the patients present that way, and women are 50% of the population. And so it is just a different way of presentation of chest pain. And so we are trying to move away from calling women's chest pain symptoms and women's heart disease symptoms atypical. They're just different. They can present with dizziness. You can feel uncomfortable between your blades, shoulder blades. Sometimes there's elbow pain. Sometimes there's bloating. There's significant indigestion, which doesn't go away when you take Tums or you take some medicines over the counter, and just continues to perpetuate. Also, unexplained fatigue or sleep disturbances, noticing that there has been a change in your exercise capacity. Until maybe a week ago, you were walking a flight of stairs without stopping, and now you can't do it. Those are warning symptoms, and sometimes women's heart disease or heart artery pain or heart artery blockages present like that far more than they present with chest pain. And so recognizing these symptoms, if you're having these symptoms, talking to your doctor and having a visit with them so that you can get screened and picked up is exceptionally important. Recognize that women also present with the classic chest pain, but many times may get dismissed because in addition to the chest pain, they also have all of these other myriad symptoms. And I think that often that those get played up a little bit more. So recognizing those symptoms and talking to your providers in a very, very timely fashion is extremely important. This slide talks a little bit about key differences in chest pain, but also key differences in why the chest pain is different. And so I want the audience to know that chest pain in women can be waxing and waning. So you can have substernal pain in the chest and heaviness in the chest, and that may be your only symptom. And when you go into your doctor's office and complain of that symptom, and you undergo a stress test, it may necessarily not pick up the type of tightness of the heart artery that we're used to seeing. Because on the panel on the right, the chest pain may be because of what we call non-obstructive heart disease, which means the blockage is not 70% or higher. And it's not tight enough to be picked up on our traditional stress test. So many times patients will complain of chest pain have a stress test, the stress test is negative, and be told that their pain is not their heart, which is not true. And so when we do an angiogram, a heart artery catheterization, we will find that these women have blockages, but the blockages are not tight enough, but it is enough to explain their symptoms. But it results in less prescription of what we call guideline-directed medical therapy, because it is not to the extent that we're used to seeing in the general population. So understanding that chest pain or angina, it can be different in women, and ischemia, which is the evidence of a blockage on a stress test, is not a prerequisite for calling this chest pain or angina in women. So you can have true chest pain because of non-obstructive heart disease, where the blockage is not significant, and still have a normal stress test. Better tests are required for this. Different types of tests are required for understanding this. And so please be your advocate and talk to your doctors about this. I also want to talk about key differences in heart disease in men and women. I touched a little bit about this, but women and men lay down plaque differently. So women's heart artery plaque develops differently than in men. Think about how reproductive hormones influence the deposition of fat. Men have focal visceral fat, abdominal fat, where women can have diffuse obesity. They can have fat in their arms, they can have fat in their neck, they can have fat in their back. And so think about how that impacts, those hormones impact that. So if they can impact the differential distribution of fat, they can impact the differential distribution of heart artery plaques. The typical male pattern ischemic heart disease or heart disease heart artery blockage is a lumpy, bumpy plaque. It's a plaque. It's a athero. It is a cholesterol particle plaque with a flap over it, and it is very visible when you do a heart artery catheterization. A female pattern heart disease is diffuse. You can have diffuse disease throughout the lining of the artery of the heart. It can be concentric, which means around the lining, and make the heart artery diffusely narrow rather than the lumpy bumpy, and it's invisible. And the heart disease or the heart attack in that kind of a heart artery may be not because of the plaque that ruptured, which is most of the heart disease presentation, but because of small shearing of the inner lining of the heart artery. And so there is a difference in not just presentation, but also in how it looks. I put this in here because there are two terms that we want our patients to recognize: INOCA and MENOCA, which is myocardial infarction and non-obstructive coronary disease. And INOCA is ischemia and non-obstructive coronary disease. It's just a manifestation of different types of heart disease in women. And I think it's important for us to know that heart disease mechanism, heart disease deposition, heart disease presentation, chest pain and its presentation, and the type of heart attack in women is different than in men. This is one type of heart attack. I know Dr. Levy talked about spontaneous coronary artery dissection. This is a type of heart attack that occurs predominantly in women. This type of heart attack is not a heart artery plaque. It is a heart artery obstruction or a dissection or a rupture of the artery lining. It's mechanically different. So you can see up here in this, is a normal coronary artery, normal heart artery with normal blood flow. When you have a slight nick or a tear inside the heart artery, blood can accumulate and develop a hematoma and a flap. This is a dissection of the heart artery. It's the #1 cause of heart attacks in women under the age of 50. It occurs both men and in women, but predominantly in men. It is also the #1 cause of pregnancy-related heart attacks. Generally, patients with spontaneous coronary artery dissection are young, they're healthy, they're active, and they have no history of family disease, of heart disease. They have certain abnormalities in their blood vessels, such as fibromuscular dysplasia, which is just proliferation of the heart artery lining, and it predisposes them to this type of a heart attack. Predominantly affects women and is really a major cause. And so if you had a SCAD, please come talk to the Inova doctors and Virginia Heart doctors who will take care of you. We are a center for SCAD Alliance, or iSCAD, which is the International SCAD Registry. And this is, Inova is an enrolling site. I'm going to move on to talk about a little bit about menopause here, because menopause is another transition time. Talked about pregnancy, I talked about cardiovascular risk factors, I talked about sex-specific risk factors, I talked about differences in chest pain. And I'm going to now focus on menopause and menopause transition. People think that menopause is basically just 12 months after not having a period. But the problem in that thinking is that you're missing the entire perimenopausal time frame. There's a perimenopause, there's a menopause, and then there is a postmenopause. And perimenopause starts typically about 5 or at least 5 to 8 years before menopause, where your hormones are actually slowly decreasing. And you may not realize that. So you can have low estrogen levels, weight gain, and this will perpetuate the changes around menopause. So on top of that, if you have traditional risk factors such as smoking, family history, or high blood pressure, it can result or present for the first time as heart disease during this perimenopausal time frame. And I put this here because I want people to know that during menopause, there is an elevated risk. The estrogen, progesterone decreases, testosterone decreases, and it increases the risk of having first-time heart disease presentation, first-time heart attacks, first times being diagnosed with blood pressure problems, first time being diagnosed with arrhythmia, first time being diagnosed with cholesterol abnormalities, because the risk, the protective risk of the female hormones is gone. And then that risk of heart disease exponentially increases. And this is a good slide to think about it, because there is that crossover time frame, age 60, where that protective time frame, that protective zone of the hormones from women is no longer there. And so if you have additional risk factors, they can exponentially cause a worsening impact. In addition, because estrogen decreases, there's obviously osteoporosis, osteopenia, which is lack of calcium, brittling of the bones, loss of body muscular mass, increase in fat deposition, changes in lipid cholesterol profile, changes in diabetes profile, metabolism, decreasing subsequently and very exponentially after menopause, and that causing an increase in what we call cardiometabolic, which is increased risk of risk factors in that time frame. So in general, I encourage my patients to speak to the doctors about their risk wherever they are in their life course and how that impacts their health, especially our women patients. Knowing your numbers, talking about specific risks, and being your own advocate. I'll focus on the Life's Essential 8 to close this out, because these are essential 8 risk factors and health behaviors that if you engage in very early on, we can really take control over the trajectory of our heart health. Eating better, eating a nutritious diet, well-balanced diet. Asked a lot of questions about intermittent fasting and ketogenic diet, and one specific diet. No diet is going to save you from all your other risks. So focusing on a nutritious, healthy diet, a very colorful plate, lots of fruits, vegetables, legumes, less processed food, less salt, less whites, less pastas, less bread, less salt, less sugar, all the whites, and more of lean meat and lean protein is exceptionally important. being more active. There was a recent study that just came out that showed that for the same amount of exercise, women derived greater benefits than men. So if you exercise, it is better for you than a man who exercises for the same time. And so women patients should really focusing on being more active. Cardio exercises are excellent, but strength training and weight training is very, very important to boost your metabolism and preserve your muscle loss as menopause strikes. Quitting tobacco and hopefully even vaping is exceptionally important. E-cigarettes can be harmful long-term. They don't have a protective effect on your heart. E-cigarettes are a bridge to quitting. They are not a bridge to nowhere. So I think recognizing that and treating that as an ultimate way to quit is exceptionally important. Sleep, 7 to 9 hours of high quality sleep. Sleep duration, sleep hygiene is extremely important. It's protective, it restores your body, it helps reduce catecholamines and certain stress hormones and helps repair your body. A BMI and managing your weight, recognizing what your weight gain is yearly, recognizing that in the perimenopausal time frame, right from about 40 or 44, a woman will gain on an average about 1.5 pounds per year with no other changes in their diet and lifestyle. So that is menopause, perimenopausal related weight gain, which really needs to be focused on boosting your metabolism and preventing that. Talking about your cholesterol with your doctor, recognizing your inherent and familial risks, recognizing the bad cholesterol level and what you can do to reduce those risks is important. Managing your blood sugar, understanding and knowing what hemoglobin A1C is and how it impacts many different processes in your body, also how you can control your hemoglobin A1C with diet and with some new medications out there that are both anti-obesity medicines as well as medicines to reduce your diabetes level and your prediabetes. Managing your blood pressure, keeping a healthy blood pressure and knowing your numbers is exceptionally important. With that, I will stop and I'm happy to take your questions. I know we've already put in our slides and our numbers to call us. And thank you very, very much for having me.
Wow, I hear the applause, but it's silent. That was a huge amount of information and a lot to unpack. We have a lot of, we have almost 250 people out there and many people are posing questions. What I'm going to try to do is put the questions into categories. So don't get upset if it doesn't sound like I'm actually asking your question, but I'm going to try to kind of categorize them and put them into a bunch of groups. I'm actually going to ask two of my own first. There were two things. Well, one thing that I don't think you mentioned, but certainly something that I have seen in my career and you have seen in your career that is very specific to women as well. And that's Takotsubo cardiomyopathy, or what we call broken heart syndrome. I think it's worth at least mentioning what that is, because 9 out of 10 folks who end up with Takotsubo are women. So you want to just do that for a second?
Yeah, no, thanks for asking that. That's an excellent question. I will break this down into two parts because there has been recent evidence that Takotsubo, which Dr. Levy is talking about, is a Japanese word for an octopus pod. It's basically a pod that balloons out, and it is used by the Japanese for, really catching octopuses. It's something that they put down in the water. The octopus climbs inside it. It's got a narrow mouth and a very big ballooning, and it's a pot that's shaped like a balloon. And so once the octopus gets in there, cannot get out. But the heart can sometimes look like that. It is also called stress-induced cardiomyopathy. Cardio is heart, myopathy is heart dysfunction or heart muscle dysfunction. And it happens because of extreme surges. It's believed to happen because of extreme surges in adrenaline and catecholamines as a response to stress. The stress can be physical and can be emotional or both. A family member dying, house burning down, pet dying, being in a motor vehicular accident, close family member having some emotional problems, work-related stress, chronic stress, typically happens more commonly in women. And it is a sudden type of heart failure that can result in significant heart dysfunction, sometimes present itself as cardiac arrest, and shock, where the patient is in the ICU and is very, very sick. We have also recognized in recent times that that type of heart failure, Takotsubo's cardiomyopathy, is actually the incident that leads to a SCAD, which is a spontaneous coronary artery dissection. Because what we have seen is that in the hinge point of where this artery sits is that apical ballooning that I talked about that causes the internal shear or tear in the heart artery and presents as SCAD. So we think about the stress cardiomyopathy or heart attack associated with severe stress as a spectrum of the spontaneous coronary artery dissection. And as Dr. Levy will tell you, many of times it's a dual presentation. You have the spontaneous dissection, and then you also have the apical ballooning. So your risk factors may not be there, other than the fact that it's the same type of presentation, women typically more than men, and women who don't have risk factors typically more than men, but are experiencing significant stress. So if you have psychological stress in your life, and that brings me to another point here, is that depression, anxiety, PTSD, and chronic psychological stress is a very potent risk factor, both in men and women. And if you have that, it should be treated as a cardiovascular risk factor and should be mitigated throughout your life course.
All right, great. Thank you. I'm going to kind of try to hit you with some quick questions and quick answers because there are so many we're not going to get to most of them. But a couple of questions about, well, gee whiz, I'm having chest pain. I went to the doctor. I had a normal EKG. Does that mean I'm normal? Does an EKG tell you more than what's going on at that very second?
The short answer is no. And so the EKG can miss a lot of things. It's a very, very basic focal test. So if you don't have anything at that moment, doesn't mean anything. EKG is done in the context of a symptom. So if you have chest pain, you go into the ER, have chest pain at that time, the EKG is valuable at that point. But if you've had chest pain a week before and you don't have chest pain, you walk into the doctor's office and you get a normal EKG, doesn't mean a lot. And so having additional tests in addition to EKGs is extremely important.
Thank you. Exactly right. And so a lot of questions about non-obstructive coronary disease. You talked about non-obstructive coronary disease. You talked about symptoms with it. You talked about heart attacks with it. There are a lot of questions about how do I know if I have it, if I'm not having symptoms? If I have it, how do I treat it? And then if I'm treating it, how do I know if it's getting better, worse, or not changing? Is it something I need to continue to monitor with some sort of testing?
Good. It's excellent question. A regular stress test that we do typically will not pick this up. So you need a better type of test. And so cardiac MRI, MRI of the heart, it helps identify these types of flow changes inside the heart muscle that can be subtle. So if you haven't had a heart MRI, ask your doctor or ask your clinician to order one. It gives you what is called a coronary blood flow reserve. Fancy word for telling us what's the level of blood flow at your heart, in your heart at all times. And then they do a stress test on an MRI and see if that changes with time. So that's the kind of test that you need. If you don't have an MRI facility around you, then a PET CT or a PET scan can also help you answer that same question. So those are additional tests that diagnose it. Treatment is treating heart disease. It is heart disease. Risk factors for heart disease are risk factors for non-obstructive heart disease. It's the same problem. Controlling your obesity, controlling your diabetes, controlling your blood pressure, controlling your cholesterol, losing weight, exercising. All those things help. And they help when they're done together. And so once you have that, getting your numbers under control. There's a type of medication called beta blockers, which are exceptionally good at treating this problem, and is the first line of drugs for this. If that doesn't help, there's another agent called calcium channel blockers, also available to everybody. They're generic, they're cheap, and can be used. Once you have this, clinically is how we follow you. Typically, we don't try to repeat these tests because they're expensive. and they're not necessarily going to show you a whole lot of difference unless you don't get better, and we don't know why. But for general, we will monitor your symptoms, and most patients tend to feel better with some sort of combination of all the things I mentioned.
So I'm going to get up on my soapbox now and refer back to one of your earlier slides that showed the cause of death in women. And it's an important thing to, I think, hammer home that, you know, hundreds of thousands of women are dying of heart disease every year, and like 65,000 from breast cancer. Yet we screen for breast cancer, we screen for prostate cancer, we screen for colon cancer, but we don't screen for heart disease. And you know, when you're seeing patients who are asymptomatic but come in with some risk factors, you know, what do you recommend as a screening study?
Yeah.
And then I may ask you a follow-up question on coronary calcium
Yeah,
score.
yeah. So what Dr. Levy is referring to is a very time-tested modality that we still kind of underutilize. And we underutilize it because it's just a way of practicing that we've sort of not changed with time. And that test is a coronary calcium score, which is evidence of heart artery hardening or plaque in your heart arteries. The challenge has been with this test is that the best benefit of doing this test is in those patients, like Dr. Levy mentioned, who have some risk factors. Their risk factors kind of not well controlled. They're kind of hanging out with blood pressures that are a little bit higher than usual, not really well treated, or their cholesterol is bad, or they've had premature heart disease. When we see these patients, we try to calculate their risk of having heart disease. So it's a probability test. You know, we come up with this probability. What is your probability of having heart disease? The problem is that when we identify lower risk patients and we put them in this probability testing equation, they tend to under risk their true risk because most of these probabilities are based on older adults that have much higher risk factors. So the tiebreaker for those individuals is a coronary calcium score. A coronary calcium score is a tiebreaker. It's a decision tool. It's an aid that we can use to understand risks that are not apparent to our eyes, because seeing is believing. And if you have coronary disease, it's going to show up. Your heart artery will light up on the CT scan. The other thing that Dr. Levy probably asked me, but I will kind of proactively ask this is, you know, we're used to doing EKG gated coronary calcium score, the sophisticated EKG gated coronary calcium score. But there is a lot of incidental heart artery calcium that can be picked up on other tests. You know, people getting other types of tests. They got a CT scan for something else. The coronary calcium shows up and radiology will report it and it's in your chart. But, you know, for some reason, it's not treated the same way. So there are good ways of incorporating that into our practice and utilizing that.
You know, there was a great question. I'm not going to get to everyone. We have like 100 questions here, but and we could go on for 2 hours. But someone actually gave me a reference, and I checked the reference during the talk, and saying that there was a Harvard letter or publication that said bone density scans can predict the future possible heart attack. And I was looking at it, saying, "Gosh, I didn't know bone." You know, but you look at the study, and as they were picking up aortic calcifications on the bone density scan. So it wasn't the actual bone density that was the information. It was that other information picked up on a test, just like what you mentioned right there. But whoever
Absolutely.
asked that question, that was great. I love the
Yeah,
reference.
yeah. No, that's absolutely true. And even mammograms. Mammograms pick up breast calcification. Breast calcification in recent times is believed to be calcification. So if you have breast calcification, it's calcification in the artery of the breast. So you want to be treating that patient just like aortic calcification or calcification somewhere else. You know, we do thousands and thousands and thousands of CT scans for all kinds of reasons in this country. And there's all these incidental coronary calciums that are being missed. And if we really tried to act on them, we would be risk stratifying a lot more patients on coronary calcium. So you ask your doctor about your risk of having heart disease and whether calcium score is good for you.
And just a reminder, because we're all asked this all the time, this is a different calcium. This isn't like the calcium you need to take to keep your bones strong. This is calcium that shows up due to inflammation. There were a lot of questions on inflammation. What does it mean? It underpins a lot of vascular disease. But I wanted to go to the issue of bias and how women are treated differently, and how women's symptoms, are they always taken seriously? And does a woman who is anxious about her symptoms, and then there were other questions about, well, how do I advocate for myself if I think I'm having symptoms and they say, you're fine, lady? First, you find another doctor if someone really said that to you. But no, but it exists, and there's a literature on this. And what is it, and how do we advocate for ourselves?
Yeah, I think this is an excellent question, and it's really the basis of why we need programs like the Women's Heart Program at Inova and Virginia Heart, right? Because it is built on the fundamentals that we recognize that there is inherent bias in treating women's heart disease. I think that it is well known and well reported that women wait longer in the ER for the same test as men. Their heart disease gets diagnosed later. I think being your own advocate and reading up on it is exceptionally powerful tool. If that doesn't help, bringing a family member or a friend or a colleague with you who can be an advocate in your office. If that doesn't help, changing your doctors is important. But from the medical practice point of view, I think guidelines that we read and we write, first, it starts with how we write our manuscripts and how we present our science. We have to have a lens that is sex specific. So when we design our clinical trials, or when we design our studies that we say this drug is going to have this benefit, it has to have equal number or close to equal number of women, because women are not small men. We know this. Women are anatomically and physiologically different. So testing the device, the drug, the standard of care, the procedure, the way we do stuff, the post op, the whole care delivery through a sex and gender specific lens is important, and reporting that and having our journals report that, so that when that evidence builds and we develop our guidelines and we teach our next generation of clinicians, we have that evidence tied in very early on, so that we're designing the training of our clinicians differently to begin with. And then actually really focusing on patient advocacy and patient voices. You know, there are so many women's heart groups now, SCAD Alliance, Preeclampsia Foundation. This gives the patients a lot of autonomy, the population a lot of autonomy to express their concerns, but also gives them a powerful voice that the medical community has to listen to.
Great. I want to try to definitely hit two more topics. One's going to be hormone replacement therapy, and one's going to be diet. So you talked about how the changes in hormone affect risk and the prevalence of disease at different ages. For a woman to decide to go on hormone replacement therapy, that's a multivariate kind of decision-making process. But from a cardiovascular standpoint, what's your thoughts on that?
Yes, great question. So much of this confusion around hormone replacement therapy started because of the Women's Health Initiative. For those, Dr. Levy will know this, because it's a trial that is, that has led to a lot of misinformation the way it was reported. The Women's Health Initiative was an NIH-funded study that started in the 1990s. The whole premise of using the Women's Health Initiative's randomized trial was basically to show what benefit hormone replacement therapy had on protecting heart disease in women patients, in women. The problem with that trial was that two things. It was using hormones that were available at that time. And those hormones that were available at that time were manufactured equine horse type of hormones. They were not the hormones that are currently available, which are refined, better tested. Dosing was different. And also the patients that were enrolled in the Women's Health Initiative average age was 62. those are not the type of patients that generally need hormone replacement therapy. Hormone replacement therapy is offered to patients who are about a decade younger than the patients that were enrolled in that trial. And so obviously in those arms, there were a slightly increased risk of coronary disease and that outblown risk of developing breast cancer, which if you really look at it, was not that much different in both those groups. Since then, the practice of hormone replacement therapy has changed. And in the recent guidelines from the Menopause Society, as well as the Cardiovascular Society is, if you do not have significant coronary disease, have had a prior heart attack or a SCAD or a significant cardiac event or a stroke, you could qualify for hormone replacement therapy after discussing your risk with your doctors. Qualification of hormone replacement therapy depends on your underlying risks and testing for subclinical risks, whether that is a stress test, your exercise capacity, or coronary calcium score. For a large percentage of patients with that mindset and with that lens will qualify for hormone replacement therapy in a safe way, especially when you have very bad vasomotor symptoms, which are hot flashes, feeling terrible, dripping into a sweat, night sweats, waking up in the middle of the night, not sleeping. Those kind of women patients actually tend to do a lot better with hormone replacement therapy, and it tends to be significantly protective to their cardiac risk long term.
Yeah, a complicated question. I'm sorry, there's no simple answer. Let's go to diet. Diet. There are several questions on diet, and you talked a little bit about diet. There are those who believe, and there was a question, Dean Ornish and plant-based diet, and you can make blockages melt away in your coronary arteries if you're on the appropriate diet and don't take Western medicines. You can cure your heart disease with diet alone. Diet's important, but can diet replace what we consider to be guideline-directed medical therapy as well for people who do have, let's stick with the non-obstructive coronary disease?
The answer is no. Diet is great. It's a powerful tool. The reason it's great is because it's self-motivated, self-monitored, and essentially it's available to everybody, right? So in the diet, a healthy diet does not, once you have a coronary event, and a healthy diet is a given, you have to have a well-balanced diet, but it does not replace the additional benefits that the medicines to reduce your atherosclerosis or your risk can do. The benefit of diet is additional, additive, and in addition with everything else that I talked about, the life's essential 8. So if you are very, very good with your diet and you are a plant-based eater and you're eating leaves and you're drinking, just lots of water, you're healthy, but you are not exercising, you are in a stressful environment and you're not sleeping and your blood pressure is, borderline or stage 1 or pre-hypertensive, it is essentially negated. So it's not going to stand alone for you. In terms of the types of diet, and lots of people ask this, what kind of diet is the best? And, I don't believe there's one particular diet that's better than the others. And this is maybe just me. I am not convinced. There hasn't been a randomized controlled trial comparing all different types of diets in terms of reversing risk, and there will never be one. But I think recognizing that in general, a nutritious, locally sourced, healthier, less processed, less salty, less meat. There are pockets in our earth where people who live in certain parts of the world and have a certain type of lifestyle, not just diet, certain types of lifestyle, tend to live a little bit longer and better. So I tend to think it's all additional.
Thank you. Quick question. Someone asked, you talked about having a preterm baby as a risk factor. How do you define preterm? How preterm?
Yeah, so general preterm is a baby before 37 weeks. Then there is severe preterm, which is baby before 34 weeks. And so recognize that preterm birth can be spontaneous preterm birth, which is, you go into preterm labor and that's it. Or it is medically indicated preterm birth, which is happening because the patient is preeclamptic. And so if that patient has really high blood pressure where they have decided that getting the baby out is a way to reduce the risk of the patient, that tends to be an additional risk factor because many patients who have that preterm birth actually have preterm birth with the preeclampsia as well.
Exactly. There were a couple of questions about breast cancer and chemotherapeutic drugs, kind of a different area that falls into the cardio-oncology area. And I'm sure we're going to have an Ask the Expert on cardio-oncology as well. But for women's heart health, for any woman who's received chemotherapy for any cancer, are there cardiovascular risks associated with that?
Yes, very much so. There are certain cancer and chemotherapy drugs that elevate the risk of heart disease while you're having them. There are certain types of hormones that we treat patients with certain types of breast cancer with that are toxic. There are also newer hormone medications as well as newer immune therapy medications for other types of cancer that we do that can cause not just heart disease, but also premature vascular and atherosclerosis. So the answer is yes. Talking about your individual risk of elevation of heart disease during cancer chemotherapy, how do you monitor cancer therapy? How do you make sure that your heart disease and heart failure risk is not elevated, both during the time of receiving the chemo, but also a few years later is exceptionally important.
Well, we're down to our last minute, so I'm going to ask and answer the last question because there were some questions on, again, non-obstructive disease. I just think it's important for everyone to remember that, yes, you can have heart symptoms without having a 95% blockage in an artery, and you have very small vessels, and you can have small vessel disease. But heart attacks are not always caused by significant blockages. Any blockage in an artery, any plaque can rupture and cause a clot and cause a heart attack. So that's why it's so important, if you have any degree of coronary artery disease, to be treated appropriately with the medications that we know reduce the risk of heart attacks and death. So please know your numbers. We're out of time, and I want to thank Dr. Sharma so much for this wonderful talk.